Good evening, and welcome to Roundtable, where we talk about redefining lung cancer together, an initiative by Integrated Health and Wellbeing Council supported by Roche. I'm Ridhi Lakra, Assistant Editor, IHW.TV. According to a report by ICMR, it is predicted India is likely to witness over a seven-fold rise in lung cancer cases by 2025, compared to the situation that was earlier 10 years ago. Over the last few years, India has seen the highest number of lung cancers. However, despite having a considerable burden of lung cancer, India does not have a formal screening program for lung cancer. Issues such as cost, logistic constraint, and concerns regarding false positive rates owing to high prevalence of tuberculosis have prevented the large scale of implementation of screening, along with the other problems as well. When we talk about the diagnosis of lung cancer in early stages, we see a huge gap in terms of awareness about the diagnosis and the treatment. It is essential we talk about the treatment options available and also the financing options by the government and the private organizations. To discuss this today, we have with us Dr. Ullas Badra. Dr. Badra is a Chief Thoracic Medical Oncology at the Rajiv Gandhi Medical Institute, Delhi. We also have with us Mr. Sanjay Sinha. Mr. Sinha is a senior consultant with the IT department of Government of Andhra Pradesh, assisting health, women and child, tribal welfare and education departments. We also have with us Mr. Vivek Tomar. He's a co-founder of Rise to Survive Cancer Initiative and ALK Positive Group India. I welcome you all for this roundtable on redefining lung cancer together. I would like to start with Dr. Badra. Dr. Badra, we see a lot of people, and we believe that a lot of people believe that lung cancer cannot happen to anybody. Only people who smoke, maybe they have a family history, they can get lung cancer. But there are also other myths around that, and people only believe that only certain group of people will get lung cancer. So, if you could explain what are some of the myths we see around lung cancer, especially in India.
So I think you have answered some part of the question yourself. There are a lot of myths associated with lung cancer. I mean, the biggest myth, which you rightly said, was that it is a smoker's disease. Yes, I would like to reframe it by saying lung cancer predominantly occurs in smokers, but it is not that never smokers cannot get the disease. In fact, if you look at the data, if you have 100 patients of lung cancer, 70% of them will have some history of smoking, but 30% of patients will have absolutely no history of smoking. There are many factors which can be associated with non-smokers getting lung cancer. Passive smoking is one of the few. Pollution is definitely out of there. Genetic mutations or genomic profiling of cancer is also one. So a lot of people say, मुझे तो आज तक बुखार भी नहीं हुआ, खांसी भी नहीं हुआ, directly lung cancer. It is happening. I think Tomarji will agree with it, with a personal experience that this does happen to a lot of non-smokers. So this is myth number one. Myth number two, which is there, it is a disease of the elderly. No, again, I would like to reaffirm by saying, yes, the most common incidence of lung cancer is in 6th and 7th decade of life. But what is the earliest case of lung cancer that I have seen is 22 years of age. And the eldest that I have seen is 91 years of age. So the majority of them lies in between, somewhere around 5th, 6th, 7th decade. But there are a lot of young people. In fact, I would suggest 15 to 20% of our lung cancer patients are coming into less than 40 years of grade. Again, these people have got some genomic alteration in them, ALK or Roche or something. But lung cancer is happening in smokers, non-smokers, young and elderly. In the same breath, the third myth that I have to quote is, it is a man's disease. No, it is not a man's disease at all. It is the gender is getting, the gender divide is getting, blurred over here, very unfortunately. Again, I would suggest 30 to 35% of our lung cancer patients are women. Non-smoking women, young women who have never done anything, anything of pollution or smoking or whatever, they are getting this disease. So these are the three most common myths which come to my mind. There's another fourth myth, which I'm sure you're going to talk about later, is about the biopsy. That, biopsy karane se lung cancer phail jata hai, which I think is the most stupidest and, of the myths which is already there. So, a lot of people come. And the fourth myth, okay, fine, I'll reframe this again as saying, A lot of people say anything which is bad on the X-ray in India is tuberculosis. Anything which is bad on India is not tuberculosis. And I have been guilty in my younger years in my medicine. Anything bad, you look at the X-ray and say, "Isko tuberculosis की दवाई दे दो, 3 महीने बाद देखेंगे कि इसका अगर रिस्पॉन्स आ गया तो ये टीबी था, नहीं आया तो हम कुछ और सोचेंगे." I was wrong. I am telling you guilty as led. This is wrong. This is an absolutely wrong attitude. Do not start a patient a medicine of anti-tuberculosis only on the basis of an X-ray or a stupid blood test which is there. You need an AFB positive report to start it, and please get a biopsy done. This is to all my doctor colleagues, my younger colleagues and friends. A lot of time people don't want to get a biopsy done because they think that the patient will not get a, they will run away the moment you say biopsy or something. But एक biopsy करने से cancer नहीं फैलता है, and दूसरा, lung cancer, everything that is bad on the X-ray is not tuberculosis. So 4 myths from my side. It occurs in non-smokers, it occurs in younger generation, it occurs in females, and biopsy does not cause cancer to spread.
Thank you, Dr. Ulas. As you said, these are for the four myths what we see, and Doctor, also we see that a lot of people are, they do not agree to the fact that when we try to tell them that yes, you can also get lung cancer, so they simply deny this fact. No, we cannot, and they, as you said about the tuberculosis fact as well. Earlier, a lot of doctors also used to say that it can be tuberculosis, and the treatment gets delayed in those terms, like. Mr. Tomar, coming to you, you have been working with numerous organizations and also as a very good patient advocate. So please tell us about your journey as a patient advocate for lung cancer.
So, unlike Dr. Batra, who chose this kind of profession, it was not my choice. I got it, and I just wear it that I have to do it. So this journey started when my wife, 27 years old age, mother of 3 years of old, never a smoker, as Dr. Batra said, never a smoker, and coming from a village background where even sometimes pollution is not there, and from pharmacy medical background and working in the clinical research industry itself, got diagnosed first wrongly diagnosed with TB, and then, as Dr. Batra rightly mentioned, so just vouch on those things. And then finally, after a year or two wrong treatments with lung cancer, stage 4 metastatic to brain, ovaries, adnexia, bones, you name it. And she went into coma after 6 months because all the available treatment in India already exhausted and there was no option. It was the time of 2012 and something. So to save her, and obviously with good intention, doctors told कि घर जाइए, ध्यान रखिए, but मेरा घर पे 3 साल का बेटा था तो मैं घर ले जा नहीं सकता था. So I have to fight, and this was the year when lung cancer research has progressed globally, not in India. And I came to know that कि एक नई medicine है जो research में, clinical trial में, and that is in US. And it was good days in India कि आप medicine easily available हो सकती थी इंडिया में. But the cost was issue, and you covered it, that cost is huge issue. So it was near about, at that time, 13 lakh per month. So we sold what we do have, or that journey start, and being stage 4 resistance आया, we thought कि अगर दोबारा medicine मिलेगी. There was again medicine in US, some of the European countries, but not in India, and they said कि India है ही नहीं है. And then that day I realized कि it is research that saves lives. जो भी हम ले रहे हैं, that could only come to India through the research. So that's my first step through understanding what needs to be done. And as I always said, patient advocacy is the journey की क्या है से क्या होना चाहिए. तो कुसुम को बचाने की एक selfish journey थी, and that I started to work navigation through oncologists, pharma companies, government. I left my job, and Kusum became first patient from India to get that medicine, to bring that clinical trial जो राजीव गांधी hospital में आया था, Secret Control, and it was a huge fight to bring that trial. And she survived. She was given 6 months. She survived 7 years. She was the longest survivor at her time in India and APAC region. She participated in 7 trial medicines. She was first patient for 5 medicines. And during this journey, we see patients dying. So उसको बचाने के we realized कि we could save more lives, and I would not use the save but giving hope to other lives. तो ऐसे करके we started this journey as a patient, working with the government, policy maker, patient support group we have already created. But how to ensure, because आप भूख लग रही है, आप उसको क्रच दोगे चलने के लिए कि खाना दोगे, किसको किस चीज की जरूरत नहीं है. तो patient advocacy is to arrange all those access, affordability to lung cancer medicine, all support in India, and not to wait 10-15 years what is available in US to come to India. So that's how the journey starts. And since my wife passed away, मेरे बेटे ने मुझे बोला कि her name was कुसुम के मम्मी चली गई हैं, but there are बहुत सारी कुसुम ऐसी है जिनको आपकी जरूरत है. तो it's now 4 years मैं और मेरा बेटा इस जर्नी में कंटिन्यू रहे और इसलिए आज यहाँ बैठा हूँ.
That's so nice to listen, Mr. Toman, about that, like how you started your journey because of your wife, and now that you're saving lives of other people. Dr. Badra, I want to come to you. Like as Mr. Vivek was telling that the screening process and the treatment process earlier in 15 years back, it was very different. So how do you think, like firstly to understand, like today when we talk about screening, so what exactly happens in the screening of a lung cancer in the starting stage, if you could tell, and also how early diagnosis can help lung cancer patient?
I'll start with the second question first, because the answer to the first question is a big zero. There is no screening protocol in lung cancer right now in India at all. And then the answer to the second question is also slightly more easier. So you have, let's say you have 100 patients of stage 4 lung cancer. The median survival, हम दो तीन तरह के मीडियन सर्वाइवल मतलब अमूमन जो है वो 50वें आदमी का सर्वाइवल कितना होगा. अगेन ये एक बात लोग बहुत मिस इंटरप्रेट करते हैं कि जो सर्वाइवल है, अगर हमने बोले 3 से 4 महीने तो 3 से 4 महीने हर एक आदमी का होगा, ऐसा नहीं होता है. इट इज द मीडियन सर्वाइवल. आप 0 से 100 में रखेंगे तो 50वें आदमी को जो सर्वाइवल होगा उसकी बात करते हैं. आउटलायर्स आर ऑलवेज देयर, कुछ कम भी करते हैं कुछ ज्यादा भी करते हैं. अगर आप आज से 1970-80 के दशक में देखें तो उनका सर्वाइवल था 3 से 4 महीने. 80 से 90 में आ जाते हैं तो था वो 4 से 5 महीने. 90 से 2000 में आ जाते हैं तो उनका था 5 से 7 महीने. तो from 70s till 2000, all that median survival gained was 3 months in a stage 4 lung cancer. 2000 के डिकेड में वो सर्वाइवल मोटा मोटा बन के 1 साल हो गया. मतलब अगर आप कोई इलाज नहीं करोगे तो 0 से 3 महीने, करोगे तो 1 साल. 1 year is, it is good as far as from 3 months to 1 year, you have statistics, you are almost doubling the survival. But for a patient, just imagine, I was just imagining Mr. Tomar's plight at that time. I know him at a personal level, that is a different issue altogether, but I was just thinking, just imagine you have a 3-year-old boy, your whole damn world is in front of you, and your wife has to go through this. 1 year is nothing in front of that. I mean, 1 year is hardly anything. Then came 2008 and 2009, जबकि हमें मालूम चला कि लंग कैंसर होता क्या है. अभी तक क्या हो रहा था कि हम लंग कैंसर को एक ही तरह की डिसीज मान के चलते थे कि जी एक बंदे को हुआ, मुझे हुआ, उसको भी यही दवाई, इनको हुआ ये दवाई, आपको हुआ ये दवाई, स्मोकर को भी एक दवाई, नॉन स्मोकर को भी एक दवाई. उसके बाद से रिसर्च हुई, एंड एज मिस्टर तोमर राइटली सेड, द आंसर टू एनीथिंग इफ यू वांट टू प्रोग्रेस इज रिसर्च. दैट इज द मोस्ट इंपॉर्टेंट. रिसर्च इज सर्च एंड डिस्ट्रॉय. देन वी हैव फाउंड आउट कि लंग कैंसर एक बीमारी नहीं है. लंग कैंसर 10 अलग अलग तरह की बीमारी है. तो किसी लोगों को एक EGFR जीन होता है, उसमें म्यूटेशन हो जाती है, किसी को ALK में म्यूटेशन हो जाती है, किसी को अलग में म्यूटेशन हो जाती है. अब आप ये देखिए, अगर आज हमें कोई एडेनोकार्सिनोमा का लंग कैंसर का पेशेंट मिलता है और अब वो नॉन स्मोकर है, तो 60% चांसेस ये हैं कि उसको हम ओरल गोली के थ्रू ट्रीट कर सकते हैं और उसका सर्वाइवल जो है वो प्रोलॉन्ग कर सकते हैं. 60% चांस. इसमें 30% चांसेस हैं EGFR के होने के, 10% चांसेस हैं ALK के होने के, 10-15% चांसेस और जीन्स के होने के हैं. तो वो लोग जो स्टेज 4 में 1 से 3 महीने जी रहे थे या 1 साल तक जीते थे 2000 में, अब ALK पॉजिटिव पेशेंट जो है वो 7 से 8 से 10 साल भी जी रहे हैं. EGFR के लोग 3-3.5 साल जीते हैं. बाकी लोग भी 3-4 साल जी सकते हैं. 3-4 साल इज गुड अगेन if you look at from 3 months, 1 year point of view. But for a patient, it's very, very less. We need to do more research. We need to join hands together. And these medicines, not all these medicines are even available right now in country. ये जो हम 10 साल का डेटा बोलते हैं, ये तोमर साहब ने सही बोला कि जी, he was a very committed guy. I can tell you not more than 10% people get 3 to 4 lines of treatment because वो दवाइयां तो रिसर्च में बाहर है. या तो वो दवाइयां आप अफोर्ड कर सकते हो, जो कि 15 लाख रुपए पर महीने की दवाई है, वो बहुत कम लोग अफोर्ड कर सकते हैं. या वो दवाई किसी क्लिनिकल ट्रायल में आई जो कि बहुत कम चल रहे हैं. या आप उनसे कंपैशन एक्सेस से मंगाइए जो कि लाने में बहुत टाइम लगता है. That is why there is an absolute great need for patient advocacy. We need to sensitize people, the doctors and the people, that we need to get these medicines and we need to get the testing done. I'm sorry if I have confused you because I've touched up many lines over there. I can see Sinha Saab. So Sinha Saab, to clarify, अगर आप किसी पेशेंट का आज सर्वाइवल लंग कैंसर किसी को 70 के दशक में हो जाया करता था, सर्वाइवल 3 महीने था. 2000 में वही पेशेंट का सर्वाइवल 1 साल हुआ. अब वो सर्वाइवल 4-5 साल भी हो सकता है, 7 साल भी हो सकता है, डिपेंडिंग अपॉन व्हाट मेडिसिन डू यू, व्हाट म्यूटेशन डू यू हैव, लॉन्ग एंड शॉर्ट ऑफ इट.
Doctor, just one more thing, like to clarify, like as you said, there's no screening.
Yes.
So, like, how do people come to know that they have a lung cancer? Is it mostly in the 4th stage of the disease, or can we find out in an early stage as well?
Yes. So most of the time, again, the data says, हमने अपना data analyze किया है, we normally see around 1000 lung cancer patients per year. हमारे पास 80% लोग जो हैं वो स्टेज 4 में आते हैं, 5% एक्स्ट्रा लोग जो हैं वो स्टेज 3 में आते हैं, सिर्फ 10 से 12% लोग जो हैं वो स्टेज 1 और 2 में आते हैं. बिकॉज पहली बात तो लोग इग्नोर करते हैं. खांसी हुई, जुकाम हुई तो पहला हमारा जो है वो खुद का इलाज करेंगे, फिर मम्मी करेगी, फिर दादी करेगी, फिर बुआ करेगी. उसके बाद आप पड़ोस के केमिस्ट के पास जाओगे, कुछ दिन वो इलाज करेगा. उसके बाद नहीं जाएंगे तो फिर आप भूले बसते अगर डॉक्टर के पास चले जाएंगे तो कई बार वो भी ट्यूबरकुलोसिस की दवाई दे देते हैं. सो देयर इज, एंड देन यू थिंक अरे तो दिल्ली में पॉल्यूशन हो रहा है, अक्टूबर नवंबर में तो खांसी होगी. फिर वो नवंबर में खांसी हो जाती है, मार्च में सीजन चेंज हो जाता है, मई में विंटर में हम लोग बाहर हिल स्टेशन से जाके आते हैं. यू डोंट गो टू अ डॉक्टर, यू डोंट गेट द टेस्टिंग डन. स्क्रीनिंग प्रोटोकॉल्स आर अवेलेबल, बट दे आर नॉट वाइडली इम्प्लीमेंटेड. एज यू वेरी राइटली सेड, स्क्रीनिंग जो है अभी आजकल स्मोकर्स में है, जो लोग 20 साल से ज्यादा स्मोकिंग करते हैं उनको, और स्क्रीनिंग हम एसिम्प्टोमेटिक लोगों को करते हैं. प्लीज अंडरस्टैंड दिस. स्क्रीनिंग इज नेवर डन फॉर समवन हु ऑलरेडी हैज सिम्टम. अगर आपको सिम्टम हो गया है तो वो स्क्रीनिंग नहीं रही है. स्क्रीनिंग आपकी तरह और मेरी तरह के लोगों में, या तुम्हारे साहब की तरह, सेना साहब की तरह के लोगों में की जाती है. अभी तक लंग कैंसर में स्क्रीनिंग का सबसे ज्यादा फायदा हुआ है कि अगर आप एक्स स्मोकर या करंट स्मोकर रहे हैं, 50 से 55 साल की उम्र है, और आपका लो डोज सीटी स्कैन कराना होता है एंड ये फॉलोअप कराना होता है. पर क्योंकि हमारे देश में ट्यूबरकुलोसिस बहुत कॉमन है और अगर कुछ नोड्यूल निकल जाता है तो उसमें हम बायोप्सी करनी पड़ती है, तो इट इज इन अ वेरी 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 अर्ली नेसेंट स्टेज. लेकिन ये तो एसिम्प्टोमेटिक हो गया. जो सिम्टोमेटिक लोग होते हैं अगर उनको ही जल्दी पकड़ लें तो भी हम बहुत कुछ कर पाएंगे. स्क्रीनिंग तो एसिम्प्टोमेटिक लोगों के बारे में बात होती है.
Thank you so much, Dr. Badra. Dr. Sinha, coming to you, when we talk about as you have worked with a lot of government organizations, so when we specifically talk about the Department of Health, how does the government is supporting in terms of cancer and especially for the lung cancer?
Well, very recently, about 9 months ago, Andhra Pradesh government took a very deep look purely at cancer, and that's where I got involved. So to clarify, I'm an economist by training in public policy. So I was looking at it from that angle. So, and it's basically what Dr. Batra was also saying, that we don't have a screening program. Okay. Now, even let's take a case of another type of cancer. For breast cancer, there is a screening program available. Now, the general recommendation is that you start at the age of 40. Now, as we all know, medicine has become very global. Doctors are exchanging ideas non-stop. Now you're doing treatment of one. There is no broad spectrum treatment. You're basically giving individual treatments. Because of patents, medicines are coming in, equipment is coming in. So people's expectations are very high. But a lot of this age of 40 for breast cancer screening was set outside of India. Now, being in the government, I had access to the entire insurance data. So when I looked only at breast cancer, what I found was 16% of my patients were below the age of 40. So now, which is quite high. Now, from a public policy viewpoint, you have to set a threshold, 95. For example, for polio, we went for 100%. Everybody had to get it. For COVID also, we tried 99 and we said, we are fine, we can live with something like that. So in the same way, from a public policy perspective, we have to define a cutoff at which, let's say, so what I found was, if I wanted to do a 95% cutoff rate for breast cancer, then I had to lower the age for 34, not follow the 40. So in a similar way, there has to be more India-specific research, take the best from outside, but adapt it to Indian conditions. I know now in India, public policy, public health has become a very acceptable field. There weren't that many universities that offered it. There's greater collaboration with the doctors, and it is working. While we are talking about this, since we're talking about data, we also have, like to bring up the National Center for Disease Informatics and Research. It's an ICMR body. They do really good work. Unfortunately, they have not worked on lung cancer. So maybe we can do something about it because we have Mr. Tomar here as an advocacy person. We have an expert. And I think there needs to be a change because they are following a hospital-based system. If you compare it to the European Union or to America, where it's insurance-based, and I basically mimicked the American system because we had some advisors who were oncologists in the US, where I could go through 5 years worth of data and had the analytical tools. So from a public perspective, getting a screening program in is very, very important. I'll give you an anecdote. I know because I was working on cancer and breast cancer was the highest, and for cervical cancer also comes in as a huge burden. So we ran a screening program as a pilot in a particular village for the women. 9 men showed up and they insisted they be looked at. Out of that 9, luckily we had doctors. Out of 3 suspected oral cancer, 1 was sent for biopsy, and the remaining 6, luckily we had an X-ray machine and we could look at it, and then 2 of them had to be sent for further referral. Now, yes, it is nice if we could do this, but the fact is when we looked at the cost of running these camps, it's simply not possible for any country to run these kinds of systems. Even in the US, they are struggling because even if you have the money, you don't have enough doctors and skilled staff to run this. So I'll stop here now and say that screening is very, very important because to give you an example for breast cancer, how you communicate with public specialists. Breast cancer at stage 1 costs me, as the state government, 75,000 rupees. Stage 4 costs me 1,76,000 rupees. So it is in my best interest to run a screening program because I save money. I'll stop here now.
I mean, that is a very big burden for the government to take. But yes, we do have private sectors that they can also help and pitch in. And I hope like everybody gets an equal sort of a treatment. Dr. Bhadra, we were talking about the screening and the diagnosis. So once yes, people do come to know they have been diagnosed with cancer very lately. But do you think there is also another aspect to it that people do not come forward for the treatment so easily? Though we do, there are organizations and the government is also some way pitching in to help them. There are medicines available. Then there is another level of thing that we do not want to get treated, that we might die. That is already like a defined thing. So do you think that is one of the things that should need to be removed from the society? Do they need more counseling? The family needs to be taught about the thing that the cancer is treated, can be treated very well, and the outcomes are well. And in terms of patient can make a proper decision on them. Do we need that as well?
Yeah. I think more than the screening, as Mr. Sinha has, very aptly and rightly put it, is a very costly thing. I think screening will take a long time to come into the Indian society with the kind of problems that we have. More important is what I was saying was that patients should get treated. Again, going by the data, out of 100 lung cancer patients that you have, 35% people don't take treatment. and another 10 to 15% will not even get a biopsy done. The first myth that has to be dispelled is that the biopsy, the moment you tell them biopsy and tell them we're going to take out a piece of ear, then they'll say, oh, the cancer will spread and we will not take treatment. It is very important. And here again, I will say the patient advocacy groups, I still remember there was a serial called as Hum Log way back in 85 or 86. And उसमें जब किसी को मारना हुआ करता था ना तो उसको टीबी हो जाती थी. So, Bollywood in 80s and 90s was if somebody had to die, he had tuberculosis. Today with, and polio, these were dreaded diseases. But today with the media, with the patient advocacy groups, we all know, okay, TB ho gayi, chalo koi baat nahi. Like to me, in my hospital, if somebody gets diagnosed with tuberculosis, I tell congratulations. Tumhe cancer nahi hua, tumhe TB hua hai. So here is where the role of the past and the present patients comes over there. You need to put across patients over there. It's possible, ilaj possible, and again, पहले नहीं हुआ करता था because पहले we were saying of 6 months survival, 8 months survival. खुद ही नहीं अच्छा लगा करता था कि यार 1 साल survival में क्यों क्या बोलो. पर सर अभी क्या है कि अभी there are oral tablets that are available. Patient can actually look like you, me, and everybody else over here. They can do their work. They can join work and then they can do. This message needs to be purported across over there. Lung Cancer Awareness Month is November. We just had a 200 people workshop that we did in our hospital, Rajiv Gandhi Mein, on this Saturday, where 200 people came. And at the end of it, and I asked them, I said, our perspective about cancer has changed. To a general public right now, cancer looks, Rajesh Khanna, Anand, a lymphosarcoma of the intestine. That needs to get changed. Our media, our patient advocacy groups, our print media, audio media, visual media, everybody needs to get across over there that cancer is not a death sentence. It is just a word. We need to put that message across over there. Especially in lung cancer, the 80% of the treatment will not even cause your hair to fall. The chemotherapies, even with chemotherapies, and there are immunotherapies now. Immunotherapies, 5-year survival is 30%. So these are good medicines. But again, the cost of this medicine sometimes is prohibitory. The cost also needs to come across down. It's very easy to say we will have a 5-star treatment and all, but you need to make it accessible. The government needs to step in. We need to have more generics. We need to have more clinical trials. We need to have more patient advocacy groups. For treatment is now there, as Mr. Sinha very rightly said. Now the word has become small. We have the best of the treatment, but affordability is an issue, and this message needs to get across to the patients. I will not say future patients, to the current and future patients, that things are available now.
Thank you, Dr. Badra. Mr. Tomar, coming to you, in the same lines, how can patients and caregivers play a more active role, in lung cancer management, and also get involved in the decision making about the treatment?
So I strongly believe that no one in the current scenario is strong enough to tackle the cancer, be it government or oncologist or pharma companies or patients. It is a partnership. If we are not becoming a partner and respect each other, taking help of each other, we cannot win. And the issue is losing is not an option for any of us. We are dying, our people are dying. So that's why the role of patient advocate is very, very critical and critical. And what I learned in patient advocacy, to share the facts. So I will start to share few facts, how it could help, and from my personal experience. So I was in a meeting with lot of doctors, industry people, with DCGI office who approves the medicine. And it was a discussion like that some market, okay, they are not purchasing, selling, but it is this cost or this medicine and everything. One word was missing is patient. Nobody was mentioning patient. Everything that medicine approval. And then and Kusum was alive at that time, and she went despite her stage 4, and she and I started to speak, and whole scenario changed. And then we were talking about patients, and in that single meeting, and it was said that was a record, and that general secretary, health secretary was there also. 5 decisions were taken in that 1 hour after our talk, what patients need, and that's changed. So patients involvement actual with facts, and I'm not saying that to sympathy, come with the facts, and that's why in this answer I'm only going to give you practical and facts. they humanize the problem. And when someone look to humanize the problem, everyone will involve and find the answer. That first one. Second one, we were talking about clinical trials and research. In last 10 years, and this is an official published study up to 2017, in lung cancer, only 49 international clinical trials happen in India. Only 49, means in 10 years. So if we don't have trials, how we are going to get medicines? What we did as a patient advocacy group, we didn't have money, but we connected with the global organization and we started to collect money, but not for the treatment, for research. And right now for L positive, which is one of the lung cancer, there we have patient funded clinical trial or research, which is a vaccine for L lung cancer, which never done in past. It will be successful or not, but we are trying to bring the change and obviously working with the policy maker. Right now, I am in the advisory board of Ministry of Health, and so how to bring more cancer research locally in India, because Indian patients are different. We cannot. I remember, and Dr. Batra will agree that, for example, alectinib is one of the medicine who is photosensitive, and Kusum was first patient, and in first summer she was red from at that time, because the patients in Europe was different, the temperature was different, so there has to lot of local data has to be generated. The next thing is and I'm not sure if companies are listening, but I hope Roche is listening, that patient is not only stories, patient is the first hand experience. So involve them in the clinical trial or any research protocol design, involve them from end to end, not at the end stage, involve them in the protocol design. You will find how it could improve the everyone outcome, because we are the one who is living with the disease. And then cost, though we are not talking about biopsy and stigma, but for India, tissue is the issue. Okay, in India, if I get in lung cancer biopsy, first to find the right mutation, the cost is so huge that 90% of us can't, or 50%, 70% of poor can't afford. And if we can't afford the cost by any way, because in some good way of biopsy sampling for this biomarker profiling, it costs 2 to 3 lakhs. So how could one person afford only for diagnosis? And if we got diagnosis, then we can't afford the medicine. So some of the medicine is still 4 lakh, 5 lakh in India. So the cost is the issue. And then and we have reduced the cost. Many of the medicines are like 35,000 per month. So that's how patient advocacy helps. Next one is, and this meeting happened 2 months back with Ayushman Bharat. We talk about Ayushman Bharat scheme. There is hardly any latest treatment of lung cancer in that scheme. There is only chemotherapy. When there will be only chemotherapy, how? So like my wife, like any of your family member, a poor person family member have equal rights to live. So if by any way, if I can afford even 35,000, but a poor person can't afford, who is living under the poverty line. So why not a single medicine is there? And when I was talking with the senior official with Ayushman Bharat, why targeted therapy is not there? The question he asked, what is targeted therapy? So you understand that lack of communication, how big the gap is, that the policy maker don't know what is targeted therapy, for which we are surviving, for which Dr. Batra is saying that it is 3 years, 5 years survival, but in under poverty line in India, it is still 3 months, 4 months survival. And then to close this part, and I would say that it's a partnership, and everyone has to come together. It's one cannot do. So that's how patient advocate could help. I take your post. Thank you.
Thank you, Mr. Tomar, for that. And like as you said, like it is not a one person's job. It is a collective role of a government and the doctors, specialists who are here, and even the patient and the family members, that they get involved in learning about the disease, and also know, like as you said, there's no available studies on that. I hope we do have more studies about lung cancer. And very important, like I want to come to Mr. Sinha regarding this. When we talk about the government policies, Mr. Sinha, do you feel like we need like there are gaps in terms of the care, and what more can be done for in terms of the patient's care? Like as Mr. Tomar also said, there's only, when you talk about the Ayushman Bharat scheme, there is only, he said there's only chemotherapy which is available in that. but not the other in the screening process. The process of the screening is not available there. So how do you think we can remove these gaps, come up with more better solutions? Like,
health is a state subject, but the fact of the matter is that the bulk of the funding does come from the center, and a lot of flexibility is given. So you have the National Health Mission, which basically funds all the facilities and the primary healthcare system. And then with the spread of the Ayushman Bharat, this PMJAY Arogyashri scheme, so states also have been given some flexibility. So some states are doing it very simply. They take a defined package and they tender it out. And insurance companies will be like any tender package. Here are 3 million people. This is their demographics. How much premium do you want? Whoever gets the lowest bid gets to run it. Some states have gone for their own health trust. So Andhra Pradesh has done that. We assume the risk internally based on the money that is coming in. And the state has also opted to give in some extra benefits also over and above. You're free to cross the 5 lakhs. The center will not reimburse you, but the state is doing it. So again, I think advocacy is important because in Andhra Pradesh, thalassemia patients get an extra cash benefit for a lifetime. So in the same way, that happened because there was advocacy for it, people pushed for it. So advocacy does pay off. Now, we also have to recognize that we have to start leveraging as much as we can. So for example, the government came up with the independent policy which said every district must have a medical college. So when we were doing our cancer strategy, we jumped on that. And we said, okay, there is a shortage of DMs and MCHs, the super specialists, because cancer has become like a super specialization now. So then we tied up with using PPP more, because some of these radiation machines cost up to 15 crores each, and they only have a life of like 5 to 7 years. And so we also came up with paper mode, getting the medical colleges to come in, keeping the costs down. The primary way for the poor people, because they are the ones who are coming under the Arogyashri scheme, because the cutoff limits the income limits are quite low. So out-of-pocket expenses do get very high. When I was talking about the breast cancer, I'll give you an example. Stage 1 is 15 nights of hospital stay. Stage 4 is 58 nights. That's nearly 4 times more. And if you take into account the out-of-pocket, just not only for travel, but also for lost wages by the family and things like that. So from a public policy perspective, we have tried to tackle it that way in terms of minimizing the cost. So what we want to do is have the initial screening as much as possible to be done at the local PHC level. Now, what AP has tried to do is, in addition to one doctor who's posted at the PHC, we are also, sort of mimicking the UK's physician scheme, where there'll be one physician who basically travels to all the villages under its area. So our hope is that this will be sort of act as a screening program where the doctor, all that he does is just travel around to the different villages. And another benefit that AP has is in every panchayat, we have something called a health assistant, who is actually an employee of the health department, who keeps control of, tries to figure out what is happening. So these are the types of low-level interventions. I mean, let's face it, financing is a big issue. And state is pretty much following the center's lead. We really do not have, we cannot set up protocols for trials and everything else. It's all run at the central level. State is just pure execution. So there really is not much a state can innovate in this area, I'm sorry to say.
That's true, Mrs. Sinha. as you said, like state has a limited option, but yes, there are people who get a lot of benefits out of this as well. Dr. Badra, coming to you, like you were talking about like the various treatment and the screening options, like how it has become very advanced. When we talk about like there are biomarkers and there are also personalized treatment like the targeted therapies. So do you think that these options available, people should worry that the treatment is still, not possible, or are there any, like in the case, not in the case of the stage 4 thing, but whereas when the patients have been diagnosed in early stages, so do you think they should be worried, or like over the years it has evolved, the treatment process in India, especially in India, when we talk about India, it has evolved. Do you think that is a thing, or we still need to work on more in these lines?
No. I think the treatment definitely has evolved, and I will not say. I think the first line treatment, which probably anybody will get in US and which will get over here, will probably do almost a very equal, decent job. It is the second, it's a plan B and the plan C, which is the problem. See, research is where your plan B, your plan A is going to be by and large the same. The early stage, you get a surgery done, you get some chemos and stuff like that done. Somebody gets in stage 4, you get a biopsy done, and then treat them accordingly. A lot of medicines are available in stage 4. A lot of medicines are not available in stage 4. 30% of medicines are not available. The important thing is probably the percentage of patients in US who are diagnosed in first stage or second stage or third stage in US is, let's say, around 50-60%. In India, it's around 20%. The patients who are able to access treatment in US are, let us say, 80%. The patients who are able to access treatment in India, even if they are stage 1 or stage 4, are lesser. So, it's a very simple thing. It's almost like saying, somebody isn't IIT good enough? Yes, IIT is good enough. And IIT college is at most at par with Harvard or something like that. But how many children actually get into IIT? So it's a percentage, let's say 70% of people take treatment over there. It's only 40% of people who take treatment over here due to a variety of reasons. That is something. So people who are willing to take treatment, absolutely good and everything. But not everybody will have the same opportunities as a normal person in US. The bar over there is slightly higher. The bar over there is lower. My take.
Mr. Tomar, like in the similar lines, like when we talk about like doctor was telling about like this, there's a stigma as well. So like people do not get treated. A lot of people do. So do you think like how can we remove this and how can we fight back? Can we combat the entire problem of stigma around it? Like now that we talk about the facilities available, yes, it takes time to get funds and all, but there are treatments. So how do you think we can combat this part of like the stigma that the treatment is not easily available, or maybe you might die during this process? So how can we remove this part? And as a patient advocate, what do you think should be done?
Sure. And I'm happy Dr. Sinha is here. And Dr. Sinha, as a patient advocacy, first rule is always challenge where you think you could, or suggest where you could think. And when you find a policymaker, grab her. Don't leave that opportunity. So Dr. Sinha was mentioning about a lot of breast cancer data, because every government focuses only majorly on the breast cancer. So let me start with this fact that women died of lung cancer is much more than women died of breast cancer, colon cancer, and other cancer combined. So more women are dying because of the lung cancer than breast cancer. This is the fact. Yes, it is. The second one is last month, October was Breast Cancer Awareness Month. From Delhi, India Gate to Mumbai, to Hyderabad, Charminar, everything was pink. This is Lung Cancer Awareness Month and nothing is happening. Government has to just invest in the bulbs like they did for breast cancer. Can they just do it that for lung cancer awareness, they could use the white light, which is, or something like that, white ribbon or something, just 1,000 rupees additional cost or less cost than breast cancer could remove the stigma. So that Dr. Sinha, and I hope next year when I will be in Andhra Pradesh, YJAC, I really want to see this change, at least in your government. The third point is, when you spoke about the stigma, give me another fact, is if we say that non-smoker, never smoke, non-smoker, never smoker lung cancer is a separate disease. If we categorize it separate disease, it is the seventh, it will be at the 7th rank for the cause of the death in the world. Okay, so if we never कैंसर और नेवर स्मोकर्स का अगर लंग कैंसर की डेथ करते हैं, वो अलग से अगर एक डिजीज बनाते हैं तो इट इज 7th रैंक, इतनी डेथ कर रही है. तो you can see that which Dr. Batra was mentioning is it is not about smokers disease. The fact is anyone with lungs can get lung cancer. And if you go to the thing and with the patient advocacy stuff, कुसुम और हमने जब वो थी जब बोला था, because we went to media, we went to social platform, and which was not easy. And अगर आप हमारी पुरानी वीडियो जो भी सोशल मीडिया पे हैं और बहुत सारे नेशनल मीडिया ने भी कवर किया, आप उनके कमेंट्स में जाएंगे, लिटरली गालियां मिली हमें कि स्मोकर होगी, झूठ बोल रही है, स्मोकिंग करती होगी, इसके पति ने स्मोकिंग किया होगा, इसके माँ बाप ने स्मोकिंग किया होगा. तो मतलब कहाँ से निकल के आएंगे हम, कहाँ से, हम एक तो मर रहे हैं, ठीक है, उसके ऊपर इतनी गालियां मिलती हैं. एंड दैट थिंग गवर्नमेंट कैन हेल्प, उनको वी ऑल शुड कम, इतना तो चेंज करवा सकते हैं ना. क्योंकि डॉक्टर बत्रा ने एक बात बोली थी कि मतलब बहुत पेशेंट्स चाहिए, एवरीवन इज सेइंग कि पेशेंट आए, चेंज करेंगे, पेशेंट एडवोकेसी कहाँ से आएंगे. देखो 2 रीजन है, एक तो लंग कैंसर में सर्वाइवल अब भी कम है, कितने पेशेंट 5 साल से ऊपर पे हैं, हार्डली काउंट कर सकते हो आप इंडिया में जो हैं. तो हम पहले तो बचते नहीं है, तो बचेंगे नहीं तो हम एडवोकेसी कहाँ से करेंगे, जब तक वे जिंदा हैं तो जब तक हैं, ठीक है, मैं आज हूं, कल को मैं नहीं हूंगा, पर ये काम नहीं रुकना चाहिए. दूसरा रीजन ये है कि अगर आते हैं, आई स्टिल गेट अब्यूज, कम से कम इतना तो हम चेंज कर लें. तो मतलब आप स्टिग्मा ले, और जब इतना स्टिग्मा रहेगा तो फिर ना तो आपके पास फंडिंग होगी, ना रिसर्च होगी, और ये स्टिग्मा हटाना इतना जरूरी है. और खाली डॉक्टर बत्रा मेंशन सम ग्रेट डाटा, एंड इफ आई लुक एट द दिल्ली एनसीआर वेयर एक्चुअली पॉल्यूशन इज अ बिग रीजन. और इस साल वर्ल्ड लंग कैंसर कॉन्फ्रेंस जो वियना में हुई थी, उसमें प्रॉपर डॉक्यूमेंटेड डाटा पब्लिश हुआ है कि पोल्यूशन इज नाउ द सेकंड लार्जेस्ट कॉज ऑफ लंग कैंसर आफ्टर स्मोकिंग, ओनली पोल्यूशन अलोन. और इंडिया में लैंडसेट की स्टडी अगर आप 2020 की देखते हो तो उसमें इट इज ऑलमोस्ट द सेम रीजन, 50% से थोड़ा 49% एयर पोल्यूशन इज द कॉज जो रहा है इंडिया के अंदर. जब आपको पता है इतनी चीजें हैं तो देन वी हैव टू कम आउट, चाहे वो पोल्यूशन के खिलाफ हो, चाहे स्टिग्मा के खिलाफ हो. अदरवाइज like there was a report published last week from one of the big hospital in Delhi NCR, एक साल पहले दूसरे हॉस्पिटल से आई थी, 60% न्यू लंग कैंसर केसेस आर नेवर स्मोकर्स, फीमेल एंड यंग, उसी ग्रुप में है. एंड हम बात करते रह जाएंगे, पता नहीं चलेगा कब हमारे घर में किसी को हो जाएगा, बिकॉज वी लिव इन दिस कम्युनिटी, आप सांस लेना नहीं छोड़ सकते हैं. सो आई थिंक हम लोग मिलकर आज अगर आज जाते हैं यहाँ से कम, बिकॉज वी हैव यू मीडिया, I patient advocate, Dr. Batra the leader in the oncology, and Dr. Sinha from the government, at least इस स्टिग्मा वाले पार्ट को अगर हम 1 साल में रिमूव कर पाए या कम कर पाए, I think this is the biggest win of this today. Thank you.
Thank you, Mr. Tomar. Like coming to an end to this conversation, I would like to, yes, Mr. Sinha, if you want to add something. Yes.
I just want to add what Mr. Tomar said about the statistics, how lung cancer is actually much higher. I mean, he's coming from the ground, he's lived it. So I really would like to follow up on it. And what I had mentioned previously about the ICMR, the disease and research people, it's hospital-based. Again, all these methodologies are defined. There's a globe scan report and all the statistics come out. And I think now, platform with 3 people like us and with Roche and a journalism backing, maybe that also needs to be done. We can do some fundamental reform in terms of how statistics are generated. We need accurate statistics, because if lung cancer is that big, we really need to focus on it, because it's a public loss, and forget about when the family's misery is always there. If you take the two together, we really have to, I think, relook at how we collect data, how we develop policy. I'm sorry, I'm not a medical person, but that's the best I can offer from my side.
Can I tell you, sir, one small point? It is not as big, it is bigger. One, it is bigger, and what I've learned in COVID is the bigger the crisis, the bigger the opportunity. I'm telling you, the lung cancer is the poster child of personalized medicine. If you want to make an impact with, breast cancer, still a lot of chemotherapy and stuff like that. Here you can transform the lives of people. As Vivek ji rightly said, his wife was in coma. I mean, imagine somebody in coma and then living for 6 years. Imagine अगर वो थोड़ा और जल्दी आई होती तो क्या क्या कर लेती. It is a big crisis, but the opportunity to do something worthwhile is bigger. That's what I would like to say.
Thank you so much, all of you. Like, we come to an end to this session, but I would like to ask you like a takeaway points in terms of the screening, in terms of new policies, what we can come up with, also in terms of creating an awareness about this. As Mr. Vivek was telling that the government is not talking about this lung cancer, though it is one of the biggest issues here in India, but we still talk about the other cancers. Yes, though other cancers are also important, but we need to talk about this as well. I want to ask like all three of you your takeaway points in this, starting from you, Dr. Badra.
So my takeaway point is very simple. Lung cancer is a real threat. It will happen to a lot of people. It is the single most cause of cancer-related deaths. If 100 people get diagnosed with lung cancer, 70% will die. It is a threat. It is a crisis. Young, old, smoker, non-smoker, male, female, everybody is getting affected. Smoking, pollution is in effect. I think patient advocacy programs, it is time to make a change. We need to make a noise, which we probably are making, but the noise should happen not only in the month of November and on 31st May when there's a World No Tobacco Day. It should happen every day, every month, every week. And as Tomarji very rightly said, I would just like to differ, don't grab a policymaker only. I mean, whenever you meet, even if you don't meet, you should get hold of them. We need to get the mindset change over there actually.
Mr. Sinha, your takeaway points.
I think, it's been eye-opening for me to realize how different lung cancer is. And, we have to take advantage of what plays well in the public. Right now, air quality, is very big. India is becoming more and more industrialized. We have no idea how much the industrial sector, all the workers who are there, how much lung cancer they are suffering. For example, asbestos got banned because it was creating, some lung issues and things like that. So sometimes we might have to just latch on to other objectives to get our voices heard, because it's a very crowded media space right now. Getting people's attention is very difficult. So whatever means necessary, I think we'll have to get creative and to get to the limelight is my concluding thoughts.
Mr. Tomar.
I think Dr. Sinha has said, I'm not sure if I could add or say much better, but still, if I would try is, and because we are quoting ICMR a lot today, so in ICMR quoted word, lung cancer is taking the face of pandemic in India. And this is exactly what by ICMR. So there are quick wins, there are low hanging fruits which we could do, but it will take time to implement that. So we have to act today before it's too late. You can avoid lot of things, you cannot avoid breathing. So obviously air pollution, these things are important. Research saves life. You cannot wait for 10 years to a patent go and then if generic come, I may not live, because the survival rate in India for 5 years is still in APEC is only 3%. Okay, so our family will die, and this grief will make you die one day, and no one is safe. The third one is anyone with lungs can have lung cancer. So removing stigma is again the low hanging fruit. And last one is we have to be partners. Involve patient advocate, involve yourself. Let's change each other, let's support each other, but we have to act today to make our future better. Otherwise, it will be too late. Thank you.
Thank you everyone for joining for this session, and I hope like we are already started creating a ripple around this, that yes, we need to talk about lung cancer, and we need to create more awareness amongst people about the disease, about the screening, about like maybe in the early stages, and also about the treatment options available. And I hope government also brings more policies in terms of the treatment options, in terms of giving better treatment to the people and equally. That's more important. And I would like to, on behalf of the IHW Council, I would like to thank Mr. Sanjay Sinha, Mr. Vivek Tomar, and Dr. Ullas Badra for joining us and talking about this, and creating a very like a very important question amongst people, that there is no doubt there is a treatment, but people still are not talking about lung cancer. Thank you so much, everybody. And I would also like to thank Roche for doing this session, and on behalf of IHW Council, I would like to thank them as well. Thank you, everyone. Have a great evening.